Hello and welcome to PROCURE Health Talks. I'm Kim Sullivan, your host, and before we dive into today's content, of course, we love to take a moment to thank our generous donors and collaborators for making this webinar possible. The topics covered in these webinars are based on questions and concerns raised by patients who contact our support line just like you. Please note that you can always subscribe to our YouTube channel to stay updated on future broadcasts. And today I am delighted to introduce you to Dr. Paul Toren. He is a uro-oncologist and researcher at the CHU de Québec. Dr. Toren, welcome and thank you so much for joining us.
Thank you very much.
Today we are going to be talking about hormonal therapy, and I want to start with the very basics of when would hormonal therapy actually or typically be recommended?
Sure. So hormone therapy is used as a systemic therapy. That is to say that it treats not just the prostate, but the whole body. So we typically use it for patients who have cancer, not just in the prostate, but elsewhere in the body. And so that's the main indication for hormone therapy. Whether that's elsewhere in the body that we see on imaging or not is variable, but on the whole, for most of its use is in patients with metastatic disease. There are two other indications where we will use it. That's one with radiotherapy. It's often given in combination. And then in other patients who just have a PSA recurrence after local therapy, those are some patients where we give hormone therapy as well.
And usually if the cancer has progressed to elsewhere in the body, is it because it's recurrent, or it could be just a first-time discovery that it is in multiple locations?
So both apply. It could be patients who present with the disease outside the prostate or that it recurs elsewhere.
Okay. And what are the different forms of hormonal therapy for prostate cancer?
Sure. So just to define hormone therapy, the definition is more or less it's a treatment which decreases testosterone, because testosterone is like the fuel for the prostate cancer car, if you will. And by cutting it, the car doesn't roll. And so you stop things from developing, you stop it from spreading. And that's the basis of what hormone therapy is. There are different ways that you can give hormone therapy. There are injections that essentially prevent your brain from stimulating your testicles to produce testosterone, and that cuts the supply. There's antagonists, there's agonists. They work differently, but the end result is the same, is that there's no testosterone being produced.
And are there significant differences if we talk about effectiveness and side effects if we compare standard hormonal therapy to next generation hormonal therapy?
Sure. So next generation hormone therapy is referring to a type of treatment that blocks the action of testosterone. So we can block the production, we can block the action of it with what we call inhibitors. And these are not the same thing, but they work, if you will, on the same axis. It's all the testosterone stimulating the prostate cancer cells, which then grow, multiply, or spread. And so by blocking it at different points, it has a better efficacy.
So standard blocks it and next generation reduces it, or the other way around?
The other way around.
The other way around. Okay,
yeah,
so standard reduces it, next generation blocks it.
Sure. Again, there's different terms that are thrown around. Next generation hormone therapy used by some, other will call it next generation AR antagonist. The AR is the protein that binds to the testosterone in the cell. And so, and there's different forms of that, AR receptor antagonist, if you will, or that next generation hormone therapy. There's ones that block it or block the production within the cell, called abiraterone, and there's others, apalutamide, darolutamide, enzalutamide, that are also used.
So what would be the criteria to determine if you're blocking or if you're stopping? If you're reducing or if you're blocking?
Sure, it's not necessarily one or the other, in fact, and most commonly they'll be given together now, because we find that giving them both together improves outcomes for patients who present with metastatic disease. So one of them is a bit more of the foundation of treatment, that is to say, taking away testosterone is something that we do in patients with advanced prostate cancer that starts at the beginning and continues in a sense to the end. The other therapy, which blocks the action of testosterone in the prostate cancer cells, is given in combination at the same time. It works better, but it may not work forever. In fact, with time, the cancer becomes resistant. And that's when that may be changed for something else, while the other treatment, which reduces testosterone, in most cases is continued lifelong.
Okay, I find this super interesting. So let's talk about the specifics of standard hormone therapy. How does it happen? Through injections? How does it work? What are the roles at play? What's needed?
Sure. So to reduce testosterone, you need to stop the way the body produces testosterone. Yeah. And there's something in your brain called the hypothalamus, which signals to the testicles to produce testosterone. And you can modulate that hormone with an injection, which essentially stimulates it and then cuts it out, as it will. It gets tired out and doesn't work anymore. The end result is there's no signal to produce testosterone. Okay. And so that's one way. Another way is to essentially block the action of that molecule, which comes from the brain to the testicles, so that it can't bind in the testicles to stimulate production of testosterone. So whether it's sort of tiring it out with what we call a superagonist, or whether it's blocking the action, the end result is there's no testosterone produced.
So now let's talk about the specifics of a standard hormone therapy by injection. How does it work, and how does it play in a treatment of prostate cancer? Sure.
So the standard or base of treatment of hormone therapy is to decrease testosterone. And the way it works, these injections, there's actually two ways it works. One way is that the injection stimulates your brain to produce testosterone, but it does so not in the normal physiologic manner where it goes up and down, but in a constant manner. And essentially by doing so, it tires out the body and it doesn't work. And so by super stimulating it, it stops the production of testosterone. The other way it can work is essentially by blocking the action of the molecule that stimulates testosterone to be produced in the body. And so those are what we call agonists and antagonists. And they're given by injections, either 1 month, every 3 months, or every 6 months typically.
So that would block the production?
Yes, it's a molecule that your brain sends to your testicles to produce testosterone. And by either super stimulating it so it gets tired out, or by blocking the action of that molecule directly, you don't get the signal and no testosterone is produced.
So patients often ask why they have to use an oral therapy for 30 days before actually going into a standard hormonotherapy by injection.
Right. So again, it has to do with the agonists, or the ones that stimulate the production of testosterone. When you give too much of that stimulation, it wears it out. But at the beginning, when you get the initial signal from the injection to produce more of the signal to produce more testosterone, in essence, you do produce a bit more testosterone initially. And so if you're on the edge and your cancer cells get a push to produce a bit more, even if it's just initially, that can be a bad thing. And so that's the reason why that we block that action of testosterone with the other molecules. So it works in a different way by blocking testosterone. So even if there is a little surge, what we call, or a little increase in production initially, then it gets stopped by the other drug that you're taking.
So it's basically reducing the chance that that surge causes any damage.
Yes, exactly.
Okay. Patients also often ask if the surgical removal of testicles is an effective procedure for standard hormonal therapy.
Sure. So we're talking about injections that block the signal to produce testosterone. Well, if you take out the testicles, there's no signal received and there's no production of testosterone. So in effect, it's the same thing. At the end of the day, there's no production of the testosterone by the testicles. And so we call it in medical jargon orchiectomy, or a surgical removal of the testicles, is a very effective treatment. It's just as effective as the injections. It's not the same thing, of course. You have a surgery, you have no more testicles, but it's a one-off thing. And so it's actually a very reasonable option for people who know that their treatment will continue for the rest of their life. Obviously, if it's something like radiation, where you only have a period of treatment, don't do that. But for someone that is going to be on hormone therapy for the rest of their life, they don't have to get injections every so many months, and it's just as effective.
I guess there would be less side effects if they don't have to get injections every few months, if they don't have to...
Well, you don't have the problems of injections, but the side effects of the treatment are actually related almost entirely to the fact that testosterone is low. So the side effects are essentially the same.
Okay.
Yes, there's no injection problems, but other than that, it's pretty much the same side effects. And of course, the side effects are irreversible if you do a surgery, which is one difference as well.
And is it an option that you often recommend, or?
I think it's a very valid option for patients who are going to continue hormone therapy for life.
As you said, yeah.
Particularly if they want to avoid the inconvenience of having to go in multiple times, and they're not concerned about having a small surgery, a day surgery typically, that will address this. And so it's a very reasonable option. I think sometimes it's not always brought up, but it certainly has its place in advanced prostate cancer.
So we talked just a tiny little bit a few seconds ago about side effects. Standard hormonal therapy actually does have quite a few side effects. Are they all the same for all patients, or depending on the cancer you have, it would be different?
Well, certainly in my experience, it's not the same for all patients. Okay. Many patients, for knowing all the side effects that can possibly arrive, many patients do very well. It's sometimes a bit surprising, but really many patients do quite well. There are many side effects which are common, however. One of the most common is a lack of energy or fatigue. Mm-hmm. And that's related to the fact that testosterone is important for energy, for fatigue. And so that's a common side effect. Many men also get hot flushes. It's like a menopause in women a bit, essentially. The changes in hormone results in hot flushes. There are other things that testosterone in the body is important for. It's important for the maintenance of your bone strength and your muscle strength to some extent. And so we usually put patients on calcium supplements and vitamin D supplements during therapy to decrease the risk of having weak bones or fractures. Testosterone is also important a bit for the psyche, and so some people have mood issues that can arrive, and that may be in part to being more fatigued, but certainly these are some of the different things that can arise with hormone therapy.
Is there anything that our patients can do to mitigate those side effects before?
Certainly there are. I didn't mention, but there's also metabolic changes which occur with altering your hormones like this. And so following up with your family doctor to follow your blood pressure, to follow your cholesterol, to follow your lipid levels, these are all helpful things to follow and to prevent other things that may arise. You can get some weight gain, and so I always counsel my patients to do exercise. It's on the whole good. There's really no bad side effects, and it helps mitigate against things like weight gain and changes in cholesterol and so on. And so that's very helpful. It also is helpful for the strength of your bones, and so it's helpful at many, many levels. So following up with your family doctor for basic blood work, keeping a healthy, active lifestyle. Certainly if you're smoking, it helps to quit smoking in that area and maintain activity. Strength training can be helpful as well. All within the range of what's reasonable, but these are things that patients can focus on. And this does help, I think, their mental well-being as well. And so yes, certainly I think there's a lot, in fact, that patients can do in this space that will help things to go better.
And how long is the duration of a standard hormonal therapy?
So it depends. Certainly for some treatments, like with radiation, it's usually a period of time that's defined. It can take a while. The testosterone doesn't necessarily come up right away after. Many patients with more advanced disease are on hormone therapy for life. And so that is a reality for many. There are patients who we can give the treatment and then stop it because things are going well, and then restart it again at a later date. But many patients who are on hormone therapy have a certain perspective of having it in the long term.
And for life, those are the patients that you usually, well, not usually, but could recommend the removal of the testicle.
Well, it's certainly an option. At the end of the day, it's the same efficacy, but there are, some pros and cons, as I mentioned, whether surgery or not, injections are inconvenient or not. There are options to be considered.
Okay, so we've delved into the depths of standard hormonal therapy. Let's touch upon next generation hormonal therapy. I know we hear that a lot now. How does that work, and what role does that play in the treatment of prostate cancer?
So building on the base of taking away testosterone for advanced prostate cancer patients, we can block the action of testosterone in the cell. And so this is something we call in the medical jargon an androgen receptor antagonist, so it blocks the action of testosterone in the cell. And there are different forms of this. There's 4 or 5 different drugs that are in use, and these are more potent and more effective. So in patients with metastatic disease, for example, we combine the two because we know that the results are better giving both, and in some instances we'll have other combinations as well. But this is more potent, newer therapies that have been shown to improve patient outcomes in terms of their survival, in terms of their quality of life. And so they're very effective and very useful in improving outcomes.
So are these more an oral type of drug? Okay.
Yeah, they're typically 2 to 4 pills to take in the morning. One of them is taken with another drug that's taken once or twice a day. but they're oral pills, so it's not an injection.
So chemotherapy would fall under next generation, or?
Chemotherapy is different. So it's not targeting the what we call the axis of the androgen receptor and testosterone hormones, which is very specific to prostate cancer. Chemotherapy acts to target rapidly dividing cells. In other words, cancer cells quite often. And that's why chemotherapy is used in many different cancers aside from prostate cancer. But chemotherapy is reserved in certain situations for prostate cancer, but not all.
A lot of our patients fear the treatment of chemotherapy. Do they have a reason to fear it?
Well, I mean, it's not an easy therapy compared to hormone therapy. It's got more potential toxicity. There's certainly nausea, vomiting. They can lose their hair and things like that. And so it is a rougher treatment to go through compared to some of the next generation hormone therapies. But it is effective. And many patients also, it's worth mentioning, many patients do very well. I mean, there's less patients in their 80s who receive chemotherapy for sure. It's less common, but many patients really benefit from it. I've had many that have done very well with chemotherapy in terms of having good responses to their cancer. So it depends on your context. It is an effective treatment. It's true that it's more difficult in terms of treatment, but often it's not as bad as patients think if it's done well and followed well. And at the end of the day, if it doesn't go well, it can be stopped as well.
And would you use it in conjunction with another treatment, or is it a standalone?
Well, it depends on the context, and there certainly is nuance. Often it's used after other treatments haven't worked, and then it's your next option of something that works. There are newer treatments where giving chemotherapy with next generation hormone therapy or androgen receptor pathway inhibitors with the base of hormone therapy can be combined all three at once. That is bigger bang for your buck at the beginning if you treat it hard and treat it well. In the long term, those are select patients where we give all three. It's not your typical patient, but in some patients it can be a good option. This is something new. Through research and trials, we've noticed this in the last few years. Can be a good option for some patients. And
are the side effects different for next generation hormone therapy to standard hormone therapy? Do they add on? Do they?
That's a good question. The side effects are slightly different, but in the large whole, similar. It's because it's blocking the same action of how testosterone works in the body. So it's more potent, so there does tend to be a bit more fatigue. I mean, some of the drugs have certain side effects, whether they get a rash or whether it can have potential for liver problems. And so there are things that you need to follow according to what drug is given. But on the whole, it's fairly similar, but it's more potent. So there is more fatigue and sometimes more hot flushes, but it's not a huge leap of difference from the other base treatment.
And if it's more potent, does it mean that the duration is shorter, or?
It's more potent in the sense that it works better. And so the cancer is controlled a lot better. And so this is why we do it, because patients live longer. They have a longer time until they present with symptoms and pain. And so it's very effective. So more potency equals better response. But it is because it's more stronger, more potent, if you will. It does have some more side effects than just giving hormone therapy alone.
And duration-wise, it would be the same?
So typically the duration depends on the treatment. So the hormone therapy in advanced prostate cancer is usually given, that is to say people with metastatic cancer, is given lifelong in most instances. The additional treatment of androgen receptor targeting therapy, as we call it, is added on. And it's only added on until it stops working. And so when it stops working, then you may change to chemotherapy and other targeted therapies and so on.
So that's when those are the circumstances, under which you would recommend chemotherapy in addition to.
Yes. Yeah, so exactly. So when we have, for instance, a very common scenario is we'll start with androgen receptor targeted therapy combined with the hormone therapy decreasing testosterone. We'll start the two. It works very well in many patients, and many patients are on it for years. But when it stops working and things unfortunately progress, we have another option, chemotherapy, and that will be given with the hormone therapy continued.
Okay. Yeah. And what are the impacts of hormonal therapy on survival overall?
So hormone therapy works. It's very effective. There was a Nobel Prize won for it. It's one of the solid cancers in the body that responds to hormone therapy. There's a few examples as good as prostate cancer. Wow. It's very effective. And so yes, it does improve survival. That's very clear. Adding the other treatments also improves survival. And not just survival, but also quality of life. And so patients live better, longer. There are side effects, but on the whole, it tends to work quite well.
So you're not only a doctor, you're also a researcher. You look into a lot of the developments that are being made. What are recent developments that have been made in the field of hormonal therapy that pertain to prostate cancer, and how might these actually help in options for our patients in the future?
Well, there's a lot of research going on, so I'm not sure I'll cover the whole question. But I think there's been more combination studies where we combine one treatment with another treatment to see if it works. There's many ongoing that may improve. And it's finding the right combination at the end of the day for the right patient, which is what we're trying to do. So that, as I said earlier, sometimes giving 3 treatments at once is the best thing. And if we can figure out which patients benefit the most from which combinations, and it's often based on hormone therapy as your base treatment, if you will, and then combining it with the right other treatment to get the best response for the patient. So I think there's a lot developing. There's been specifically new treatments that we've added on to hormone therapy, whether it's what we call radioligand treatment, which is a type of radioactive treatment that we inject and homes to the cancer, whether it's DNA repair inhibition, which is a specific defect in certain cancers, which can be targeted with a specific drug. So these are targeted therapies. These are new options that are now Health Canada approved. Getting funding and access is always an issue, and that's developing. But these are now in use in Canada. These
20 years ago, this would have never been the case.
So 20 years ago, I wasn't in practice, but 20 years ago, they basically had chemotherapy and hormone therapy, and that was it. And 20 years ago, the outcomes, particularly of patients with resistant advanced disease, was much poorer than it is now. We see patients in our clinics who are followed for years and years. So it's good to see, and there's certainly room for more improvement.
Well, there is always room for more improvement, always room for more research, and always room for a lot of questions. What resources would you suggest for patients who might not have their next appointment until a month from now, but have all these questions that they...
Yeah, so it's good to ask questions because it helps you understand. And so I would encourage patients to seek out answers. Some of the resources that I refer my patients to include the PROCURE website. There's a good book written by a colleague that has excellent information. There's when you look at websites, it's important to know that it's a bona fide website, that the information is reviewed by doctors. There are some good ones out there, but you want to make sure it's approved by people who work in the field and who vet the information. Your local doctors, obviously, your local radiation oncologist, urologist, medical oncologists are good resources, and they often have some team members as well that can be helpful to reach out to.
Well, thank you so much. I'm sure that you clarified to many today the benefits and differences and everything that happens with hormonal therapy. It could be a scary thing for our patients. So we truly appreciate you being here, Dr. Toren, and enlightening us on the topic.
Thank you very much. My pleasure.
And for all of you listening, thank you so much for joining us. We hope this webinar has been instructive and helpful. If you have any questions and concerns, please contact our free and confidential support line. It's available 7 days a week. And also we have a dedicated team of nurses here at PROCURE that are always willing to assist you. You can visit our website for more information. And once again, we thank you and we thank you.
Nous remercions chaleureusement nos partenaires et collaborateurs pour avoir rendu ce webinaire possible. Pour accéder en tout temps à des outils et ressources au sujet du cancer de la prostate ou pour faire un don, rendez-vous sur procure.ca. Merci pour votre soutien.